Good morning. Today's journal topic is Initial Invasive or Conservative Strategy for Stable Coronary Disease. My moderator is Dr. Tanmay Bhatt. Introduction. In patients with stable coronary artery disease and moderate or severe ischemia, whether clinical outcomes are better in those who receive an invasive intervention plus medical therapy than in those who receive medical therapy alone is uncertain. Goal of treating patient with stable coronary disease are to reduce the risk of death and ischemic events and also to improve the quality of life. Before the availability of drug-eluting stent, studies have shown that revascularization added to the medical therapy did not show reduction in the incidence of death or MI compared to the conservative management. But after the availability of drug-eluting stent, uh, the studies have shown added to the medical therapy, it decreases the incidence of urgent revascularization, but not the incidence of death from any cause or MI, whereas 5-year follow-up shows a marginal decrease in the incidence of MI. Methods. Trial population includes the patients with stable coronary artery disease after clinically indicated stress testing, which showed moderate or severe reversible ischemia on imaging test or severe ischemia on exercise test without imaging. Exclusion criteria include patients with estimated GFR less than 30 ml per minute, recent acute coronary syndrome, patients with unprotected left main coronary artery stenosis of at least 50% on non-invasive coronary CT angiogram, ejection fraction of less than 35%, patients in NIHA class 3 and class 4, unacceptable angina despite the use of medical therapy at maximum acceptable dose. Treatment strategies. Eligible patients were randomly assigned in 1:1 ratio to an initial invasive strategy with angiography and revascularization or to an initial conservative strategy of medical therapy alone, but with angiography reserved for failure of medical therapy. Randomization was performed with interactive voice response or web-based response system with the use of randomly permuted blocks of varying sizes with stratification. Patients in the invasive group underwent angiography within 30 days after randomization and complete revascularization of all ischemic territories if feasible. Decision about the type of revascularization, whether PCI or CABG, was decided by the local heart team. Medical therapy included intensive secondary prevention with lifestyle and pharmacological interventions. This was applied equally to both the groups. Patients were followed up at 1.5 months, 3 months, 6 months, and 12 months after randomization and every month thereafter. Every 6 months thereafter. Outcome assessment. Primary outcome was the composite of death from cardiovascular causes, MI, or hospitalization for unstable angina, or resuscitated cardiac arrest. Key secondary outcomes includes the composite of death from cardiovascular causes or MI and angina related quality of life. Clinical outcomes were studied by an independent clinical event committee whose members were unaware of the trial group assignments. Statistical analysis. Totally 8,518 patients were enrolled in the study. Of that, 3,339 patients were excluded because 1,350 patients did not have moderate or severe ischemia according to the stress score laboratory, and 1,218 patients did not have obstructive coronary artery disease, and 434 patients had unprotected left main coronary artery disease. After excluding 3,339 patients, totally 5,179 patients underwent a randomization. Of that, 3,783 patients, that is 73% of the patients, underwent trial coronary CT angiogram, and Remaining 1,396 patients did not undergo trial coronary CT angiogram because 575 patients had low EGFR, 700 patients had already known coronary anatomy, and 121 patients had other reasons. So, of 5,179 patients, 2,588 patients were assigned to the invasive category and 2,591 patients were assigned to the conservative strategy. After 3.2 years of follow-up in the invasive group, 99.4% of projected follow-up was completed, 28 patients withdrew, 36 patients were lost to follow-up, 2,475 patients underwent angiography, and of that, 2,054 patients underwent revascularization. In the conservative group, after 3.2 years of median follow-up, 99.7% of the projected follow-up was completed, 22 patients withdrew, 26 patients were lost to follow-up, 667 patients underwent angiography, and of that, 544 patients underwent revascularization. Results from July 26, 2012 to January 31, 2018, total of 8,518 patients were enrolled and 5,179 patients underwent randomization at 320 sites in 37 countries. The baseline characteristics of the patients were well balanced between the two groups. The baseline characteristics of the patients include, in both the groups, the median age taken was 64 years, and predominantly the study group include males, that is in the invasive group, totally 1,982 patients were males, and in the conservative group, 2,029 patients were males, and in the invasive group, 1,894 patients were hypertensive out of 2,579 patients, and in the conservative group, out of 2,582 patients, 1,895 patients were hypertensive. Then history of diabetes is present in 1,071 patients in the invasive group and 1,093 patients in the conservative group. History of usage of insulin is present in 239 patients in the invasive group and 253 patients in the conservative group. Then regarding the smoking history, in the invasive group, 1,119 patients have never smoked, and in the conservative group, 1,089 patients have never smoked. And current smoker includes 319 patients in the invasive group and 321 patients in the conservative group. Then family history of premature coronary artery disease was present in 578 patients in the invasive group and 592 patients in the conservative group. Previous history of MI was present in 495 patients in the invasive group and 496 patients in the conservative group. Then history of cardiac catheterization was present before the enrollment in 979 patients in the invasive group and 925 patients in the conservative group. History of heart failure was present in 112 patients in the invasive group and 94 patients in the conservative group. The median ejection fraction in both the group was 60%. History of atrial fibrillation was present in 128 patients in the invasive group and 93 patients in the conservative group. History of previous stroke was present in 83 patients in the invasive group and 68 patients in the conservative group. Then history of angina was present in 2,329 patients in the invasive group and 2,312 patients in the conservative group. Among the patients in the invasive group, 96% of the patients underwent angiography and 79% underwent revascularization. That is, PCI in 74% of the patients and CABG in the 26% of the patients. In the conservative strategy, 26% of the patients underwent angiography and 15% underwent revascularization even before the primary outcome. The primary outcome, that is the death from the cardiovascular causes, history of MI, resuscitated cardiac arrest, all those things occurred in around 318 patients in the invasive group and 352 patients in the conservative group. In the pre-specified covariate adjusted Cox model analysis, the estimated hazard ratio with an invasive group as compared to the conservative group was 0.93. At 6 months, the estimated cumulative event rate was 5.3% in the invasive group and 3.4% in the conservative group. After 5 years, the event rate was 16.4% in the invasive group and 18.2% in the conservative group. So ultimately, there was no difference in the 5-year restricted mean event free time between the two groups. Then regarding the secondary outcome, there were totally 276 deaths from the cardiovascular causes or MI in the invasive group and 314 patients deaths in the conservative group. At 6 months, here the estimated event rate was 4.8% in the invasive group and 2.9% in the conservative group. At 5 years, the estimated event rate was 14.2% in the invasive group and 16.5% in the conservative group. So here also the restricted mean time free from death from cardiovascular cause or infarction over 5 years were similar in both the groups. But there were more hospitalization for heart failure and fewer hospitalizations for the unstable angina within the invasive strategy. The early increased risk of primary and major secondary outcomes in the invasive group was attributable mainly to the procedural infarctions in the early follow-up. Discussion. Over a median of 3.2 years of follow-up among the patients with stable coronary disease who had moderate or severe ischemia on stress testing, an initial invasive as compared with an initial conservative strategy did not reduce the rates of primary or key secondary composite outcomes. In the invasive group, patients had more procedural infarctions and they had few non-procedural infarctions during the follow-up, whereas the death from any cause was low and it is similar in both the groups. The rate of early cardiovascular events was higher and the rate of late cardiovascular events was lower among the patients in the invasive group than in the conservative group. Differences in the event rates between the groups in early follow-ups were greater. Data suggested that spontaneous infarctions confers a higher risk of subsequent death than the procedural infarctions. Despite pronounced difference in the frequency and timing of MI, there was no difference between the group with respect to the mortality. Longer-term follow-up with assessment of mortality is needed to fully understand the prognostic implications. The limitations of the study includes power of the study was decreased as the sample size has been reduced from 8,000 to 579 patients and therefore the event rates were also lower than expected. And in the study, the period of follow-up was also modest and the findings did not apply to the patients with acute coronary syndromes, then clinically significant left main coronary artery disease, patients with low ejection fraction, patients with class 3, class 4 heart failure, or those who are symptomatic despite the use of medical therapy, as these patients were excluded from this study. And also the study has not analyzed the effect of the completeness or method of revascularization on the outcomes. The clinical outcomes should be interpreted in the context of quality of life. So, conclusion in this study, when we compare an initial invasive strategy With an initial conservative strategy in patients with stable coronary disease and moderate or severe ischemia, we did not find evidence that the initial invasive strategy reduced the risk of ischemic cardiovascular events or death from any cause. The similar article was published in 2007 in New England Journal of Medicine, that is optimal medical therapy with or without PCI for stable coronary disease. This journal also concluded that PCI did not reduce the risk of death, myocardial infarction, or other major cardiovascular events when added to the optimal medical therapy. Thank you.